It gives me great pleasure to introduce our speaker today, Dr. Michael Lucey. Dr. Lucey was born in Dublin, Ireland, and was awarded his MD in 1985. He trained in gastroenterology at St. Bartholomew's Hospital and was actually a fellow in liver disease in King's College, both in London, and came to the University of Michigan actually in 1985, which is when I first met him. He was first a faculty and fellow there, and then became the medical director for the liver transplant program, and probably most important, became my mentor. That was a very important time for me. And he then left the university, was actually director of hepatology at the University of Pennsylvania from 95 to 2001. And since that time has been the chief of the Division of Gastroenterology and Hepatology at the University of Wisconsin and a professor of medicine in the Department of Medicine there. Dr. Lucey has a national presence. He has been the past president of the American Society of Transplantation. He was a former treasurer of the American Association for the Study of Liver Disease. And very important, he was the inaugural editor of one of our newest journals, a multimedia journal for the AASLD called Clinical Liver Disease, where he really grew that publication to a large extent during his time as editor. Very importantly and very well deserved, this year he is receiving the Distinguished Clinician Educator and Mentor Award of the AASLD, which is a very prestigious award and one that is very well deserved. And it gives me great pleasure to welcome him to give our grand rounds. He will be talking about his area of most expertise, which is liver transplantation for alcohol-related liver failure. Thank you for joining us, Michael.
Well, thank you very much. Just, I want to confirm that you can hear me. Can you hear me?
Yes.
Good. That's all I need to know. Introduction, and thank you to you today, Kim, and thank you to Marwan. It's a pity that I can't travel to Detroit and be in person, but I want you to see that I did put on a collar and tie. I mean, it's probably the first time I've done so in 6 months. So we are living in a different world, and that'll be reflected a little bit in what we're talking about today. I am going to talk to you about liver transplantation and alcohol failure. And as befits a man of my age, I am going to start by taking a grand, and I call this a new lecture because it's a new way of lecturing. I mean, it's different from being present and hearing your responses and being interrupted and being able to take a question. All of those things are more difficult now. So this lecture hasn't been given quite this form before, so I hope it works. But what I have is, let's see if my slides move on here. I've called a journey in 3 chapters. So it's partly my own journey, but it's, I hope, also going to be a journey for you, my listeners and watchers. And so it comes with a prologue related to coronavirus. This is a quotation from a recent publication. Cooped up at home, millennials are most likely among all adults to turn to food and alcohol. 1/3 of millennials say they're eating more, while 25% they're drinking more. That's the world we're living in. So we're not only have we risks for alcohol-related liver disease to start with, COVID and the precautions related to the risks of COVID have enhanced those the circumstances to make alcohol-related liver disease more likely. So the first chapter is going to be the broad view. I call it a view from space. And so this is going to look at national. Then I'm going to come closer to the earth and finally look at our own local center. So it's important to realize that the trend in mortality due to liver disease is not stable. In fact, it is rising. And these are data from Elliot Tapper and Nihar Parikh down the road from you in Ann Arbor. This is a paper that's received a lot of attention. I hope you can see my cursor here. And what it shows is that the trends in mortality that are rising for cirrhosis, whereas some other liver disease, they've picked out hepatocellular carcinoma, have been declining, at least in some age groups. But when you look at alcohol-related liver disease mortality, and in particular in this panel here, the lower right-hand panel, alcohol-related liver disease, there is a rise in mortality across all age groups, but particularly in young people. And this looks at alcohol use disorder related deaths, and they are largely contributed by alcohol-related liver disease deaths or cirrhosis. And the cirrhosis deaths and the alcohol-related liver disease deaths are almost identical. So it's this younger group that are particularly a new phenomenon for us. And I'm sure you're seeing that in your own practice. Deaths in hospital of relatively young people related to excessive drinking, even though it's increasing across all the groups. And as I mentioned, COVID is putting this pressure greatly on this group. And here's a picture from Europe. I have a similar sort of picture from the US in a minute. But I like this picture because it looks at trends in liver transplantation across the causes of cirrhosis. And I started out in a liver transplant program in 1983, which is this column here. And then in 1985 was an important year. This was the year that the NIH declared that liver transplantation was a standard of care procedure. And you can see in Europe at that time, the most common diagnosis was primary biliary cholangitis, or primary biliary cirrhosis as it was then called. And alcohol-related liver disease accounted for less than 10% of the patients being transplanted. Since that time, the actual numbers of persons being transplanted has grown. But the proportions have also changed, so that by 2001, the predominant diagnosis was viral hepatitis, particularly hepatitis C, and alcohol-related deaths, alcohol-related causes for liver transplantation, I should say, had risen to about 5%. So it was a significant reason for transplantation, but still less than for viral hepatitis. Since then, the viral hepatitis number has declined, and it's declined even more. This goes up to 2016, but is even more since then. Hepatitis C has fallen away as a reason for liver transplantation because of the advent of direct-acting antivirals. And alcohol-related, and this group here is called cryptogenic, but that's actually NASH. That has grown as well. So that in this data set in Europe, alcohol-related liver disease accounts for almost 40% of the transplants. And look what's happened in the US. These are data written up by Brian Lee, now at University of Southern California with Nora Turow. And it shows that going from 2002 up to 2016, the percentage of cases to alcohol among the transplanted population have risen from 24% around here up to 37% here. So very similar to the European experience. So we're seeing a greater proportion of alcohol-related liver disease than ever before. And there's also a rise in the number and proportion of patients with alcohol-related hepatitis, although the actual percentage is still very low to these patients later on. Now, within these data, there are more nuances, and this is a more recent paper by Thomas Cotter, who is a fellow at the University of Chicago. It's published in AJT. I'd recommend it. It's full of very clever and very interesting analysis. And I've taken two panels. They're rather boringly presented as just blocks of black print, but I'll go over them and I hope I can bring out their. First of all, it's looking at the liver transplantation between 2014 and 2019. And here he is just looking at additions to the wait list. And a mortality of patients added to the wait list for alcohol hepatitis, and this is mortality on the wait list. The number of total patients just under 600. Now it is in comparison to 76,000 additions of non-alcoholic liver disease. So the alcohol hepatitic group very small, but still enough to make a comment. And they appear to have 50% of the on-list mortality of the non-alcoholic hepatic patients. So a surprising, non-intuitive observation that these patients seem to be doing better on the waiting list, not dying without transplantation or being taken off the list. And the number taken off the list because they have improved is present, but %. And I'll relate to this group later on in my talk by just saying we've looked at this at the University of Wisconsin. And finally, looking at patients who are the sickest patients, MELs of greater than or equal to 35 at listing, 85% of these patients proceeded to a liver transplant, whereas only 77% of the non-alcohol hepatic patients did so, again indicating some preference, some benefit to the patients with alcohol-related hepatitis who are placed on the list. And this is a complicated looking picture. I wondered about even including it, but it just makes some comments also on Dr. Cotter's paper, which is, first of all, that the number of centers doing liver transplantations for patients with alcoholic hepatitis has increased from 2014 to 2019. This is still less than half of the centers in the country. And this change is probably continuing. And I suspect in 2020, this number has gone up a little bit even further. And these patients are younger and have higher MEL scores and are more often on dialysis and more often on the ICU compared to all the other patients who are placed on the list for indication. So this is a sick population who are getting placed on the list, and their graft survivals are excellent. 1 and 5 year survivals being 92% and 82%. And these are very good outcomes, particularly considering just how sick these patients are. And this just looks at the years in which the change has occurred, causing an increased number of patients with AH being placed on the list. And the greatest change was in the year 2018. So this is a flux, and only looking by year can you see how this flux is changing. But I just want to make the point that the notion that patients with alcohol-related hepatitis, those are the patients who've been drinking, should have been transplanted, is now up for discussion and is changing. Now, you might think that that would be important for patients to know this. At least I do think that that's important. The patients get sent to a transplant program largely outside their own decision making. They just get sent. So this is a recent paper published by Rita German, and our group. Rita is now a faculty member with us. She did this while she was a fellow, and she looked at what was placed on the internet to inform patients and their families about selection policies related to transplantation. And we were particularly interested in selection of patients and the relationship to their use of alcohol. And there were 141 UNOS approved centers in the country. So when we said earlier that that 47 were doing alcoholic hepatitis, you can see that it's a little over a third. And all 141 have a website. Well, that's going to come as no surprise. We then had a process to review those websites, and we found some account of eligibility criteria in just over half. But a discussion of alcohol use within those eligibility criteria was much more infrequent, only 24, 141. And a direct statement about whether or not the required 6-month abstinence before placing a person on the list was present in only 3. So there is an element of closure, of lack of candor here regarding what we do and how it affects patients. So what do we say we should do? So this is the most recent AASLD guidance on diagnosis and treatment of alcohol-associated liver diseases. You'll find it on the AASLD website. It's published in Hepatology. It came out, it's called the 2019, but it actually came out in the first month of 2020. And these are the statements that it makes, that it says, and there's much discussion, I have to say, about these. Patients with decompensated alcohol-associated cirrhosis, Child's Class D or a MELD sodium of at least 21 should be referred. Let me see if I can make this a little bit smaller. my screen is a little bit blocked here. Yes, should be referred or considered for liver transplantation. So we're declaring that we accept that liver transplantation is an appropriate treatment for some patients with life-threatening alcohol-associated liver disease. But then these are the two controversial parts. Candidate selection for liver transplantation in alcohol-associated cirrhosis should not be based solely on a fixed interval of abstinence. And then liver transplantation may be considered in carefully selected patients with favorable psychosocial profiles in severe alcoholic hepatitis not responding to medical therapy. And there was a much discussion over the verb may. Originally it was written should, and the various review committees within the AASLD considered that to be too strong and said it must be may. They're the current guidelines of the AASLD. So that's a national view. And now I'm going to take us in our space capsule, and as we re-enter the atmosphere, we're getting a little closer. So we're now going to be able to look at multi-center studies. What are they saying? They're coming into view as we descend. And I'm particularly going to refer to Accelerate AH, the American Consortium for Early Liver Transplantation for Alcoholic Hepatitis. And this is a loose organization of centers working on the basis of common interest, led by Nora Thoreau and Brian Lee, now at USC, but started when they were at UCSF. And you can see it's up to 12 centers, but in the papers, not all 12 are always represented. And we're one of the centers. And the first thing to say that there are identified 147 patients transplanted with alcoholic hepatitis, and contrasted them to just under 700 patients with not alcohol-related liver disease, principally cirrhosis. And this was a retrospective study, so the behaviors of each center were their own. There were the selection criteria and how they decide that was not determined prospectively. But in this model, the 1-year survival was 94% versus 90%, and 85% and 83%. So there was no difference in the survival between the alcohol hepatitic patients and the patients with alcoholics. And you can see the numbers are reasonably good out to 3 years. And this study also looked at alcohol use in the 141 patients who survived hospital discharge. 40 of them, 27%, returned to some alcohol use. Again, retrospectively recorded. Most of the centers use biomarkers. All of them use some sort of interview technique. The intervals between interviews and biomarker use was haphazard based on what they did at each center. And 25% had acknowledged alcohol use at 1 year, 34% at 3 years. And then when you broke that down and tried to distinguish between slips and sustained use, you see it broke down roughly half and half between the two. And perhaps more surprising was this observation, that the mortality in the patients who had acknowledged alcohol use was worse from 1 year out, and that reached significance. Now, that's surprising because in other studies, both prospective, of which there are not that many, and retrospective, looking at alcohol use after liver transplantation, this sort of mortality difference is not usually seen, at least in the first 5 years, and then is seen after that. So that this should be manifest so early was a surprise. However, this allows you to do some things. First of all, it allows you to try to work out what were the factors that predicted which patients would drink again. And Brian Lee, again, as the lead author, came up with this score. And the score it shows some of the weaknesses of scores, because if you're going to rely on patients who have more than 10 drinks a day at presentation, and 2 or more failed rehabilitation attempts and say they're the patients we're not going to take, we're probably not going to take those patients anyway. So the problem with this score is, while it works as a mathematical exercise, it did not really provide the sort of nuanced information that we'd like to get to actually apply in a prospective fashion. And so some of the data I'm going to show you today, both from Accelerate and from Wisconsin, are data for ASLD meetings, so not published. So here are some not unpublished data, and that's why it looks as dense as this. It's got a lovely title because it's a real jawbreaker. Novel quality metrics of psychosocial assessment. The next word is blocked for me. Then harmful alcohol use after early liver transplantation. Early liver transplantation is transplanting these patients with AH rather than waiting. And in this data set, there are 123 patients with a median follow-up, sorry about the error there, 4.2 years. And in this cohort, 34 of them, who are of the 116 long-term survivors, had returned to harmful use. And what this was, this is a complicated study done by Nitzan Ross and Jean Im, both in New York centers, where they have worked with experts in the use of language, and they've taken the psychosocial narratives, which were done in different ways in different centers, which makes this a difficult challenge, and tried to analyze them to see what were the important questions being asked and what questions were linked with future behavior. And they came up with 108 questions within 16 domains. And there were really 3 ways of doing this. Patients were interviewed by social worker and psychiatrist in 40 places, social worker and addiction counselor in 36, a social worker only in 42. And in this study, they've been able to define a profile of question areas which make for a more predictive or less predictive assessment at the time of pre-transplant evaluation. So more nuanced than the SALT score, which is too blunt. And what they, perhaps most importantly, I think, found that the interviews that were conducted with the assistance of psychiatrists tended to have more of these quality elements. But also, if the interviews by medical social workers or medical social workers with addiction specialists contained a broad range of quality areas, they were likely to be, they were as good as being done by a psychiatrist. So that meant that the content of the evaluation, rather than the professional identity of the evaluator, is what counts. This is an important finding because many centers don't have a psychiatrist who will work with them, but they may have an addiction counselor, or they may have a social worker whom they could train to complete the evaluation in a manner which covers the breadth of the patient's risk profile. Another consequence of finding that there was a mortality associated with return to drinking was that it allowed a modeling study, which has been published in Gastroenterology. Again, I'd refer you to it. Jag Chatwal is the modeling expert in Harvard who really helped with this. And so it looked at taking the data and then considering different post-liver transplant alcohol use categories, and then using them with the inclusion of a waiting period or the absence of a waiting period, to see how, if you have a waiting period, whether it makes a difference. And I'm going to show you 4 models. So this is what actually happened, but scenario 1, 2, and 3, and particularly scenario 1 and scenario 3. In scenario 1, all patients who are given an early transplant return to drinking, and no patient who's delayed And that is the result of the evaluation, is to say you've got to provide a delay, and we then transplant you if you remain abstinent, to our best understanding. None of them drank again. So this would be the model that most favors the notion of putting in a delay and observing the patient, somewhat along the lines of the delay in hepatocellular carcinoma management now in liver transplantation. And in this model, you can see, because everyone post-transplant who is treated early returns to drinking, that group has the highest mortal effect associated with return to drinking. And yet, they still have a 2-to-1 survival benefit in life expectancy, just over 2.5 years versus over a little over a year. Contrast with this model here, scenario 3, it assumes that every patient who is transplanted early establishes robust sobriety after transplantation. But every patient who is delayed nevertheless returns to drinking. Here you've got the best outcome for the early patients, the worst outcome for the delayed patients. And here you've got the best survival benefit. And this is what we are actually seeing, a survival benefit somewhat in the order of 4 years versus less than 1. So this is a philosophical question, not unlike treatment for cancer, because the patients with severe alcohol-related hepatitis have a mortality equivalent with a very bad cancer. And in those discussions, getting 2 years instead of 1 year is considered an acceptable outcome for any of these new drugs, and many of them which are costing hundreds of thousands of dollars. And this is what, at least in the model we saw, which is a 4-to-1 benefit. And so this really asks us the question, what are we trying to achieve? Where do we consider the appropriate success rate, knowing that there will be some returning to drinking in this population that can't be avoided? That's the nature of their underlying alcohol use disorder. So now we're into chapter 3, which I've called Coming Home, which is returning to Madison, Wisconsin. If I was cleverer with the pictures, I put a little picture, I graphed in the background of the capital and some boats here to suggest that the capsule was landing in Lake Mendota. So the first data set, the local data set I'm going to show you is from Pittsburgh. And I really want to show this because to make the point that prospective data always are better than retrospective when done properly. This is a data set from Andrea De Martini, and she was using patient self-report as the indication of drinking after transplantation. And she defined 5 patterns. And that's to point out that every person who returns to drinking has their own pattern. It's not a binary drinking, no drinking model. So some start drinking, some stop, some start drinking, some stop and start and stop and start. But these are the she chose to corral her data into. Half the patients, she had 140 patients who survived transplantation who are being followed out. She's continuing to follow them. All had been selected in accordance to the 6 months abstinence rule, interestingly. So at another time, we could actually point out that that rule doesn't stop people from drinking again. But she had 51 who appeared never to drink again, and 28% who drank very little. So this group of 80%, they're really no or almost no drinking. They're the 2 lines on the basis here. And then we have 3 groups, and they break into roughly equal groups. One in yellow here is early onset and continues drinking heavily. So this is the worst outcome. Pardon me. There's another early group here in green. They return to drinking early, but they then establish sobriety. So this is the group where you might consider medical intervention for addiction care has had some benefit. that they have now learned their lesson, and I have many patients who fall into this group. So relapse of itself, challenging and dangerous, is not the end of the story if you can actually reestablish sobriety. And this then is a very worrisome group in dark blue. They're the group who maintain sobriety or almost sobriety, look here, out to 1,000 days post-transplant, and then start drinking heavily. And I also have patients like that, patients who are shocked that their ability to return to abusive drinking after many years of sobriety, or sobriety with occasional slips, and then something triggers the return to heavy drinking. Now, what about biomarkers? And this is taken, the first sentence is taken from the text of the ASLD guidance that I mentioned earlier. It wasn't made into a guidance recommendation, but it's in the text. Alcohol biomarkers should be used as an aid to diagnosis, support recovery, and as catalysts for discussion with the patient rather than tools to catch or punish the patients. So that's recognizing one of the risks of biomarkers is that you apply the biomarker, it's in the patient's blood tests, they're not quite aware that they are doing it. They may have given permission a long time ago, and then you spring on the fact, your PEth is positive and is highly positive. Why are you lying to me? And the problem with that construct is it creates an adversarial relationship between the patient and their doctor, and it can cause a loss of trust. So that's a challenge. But there are biomarkers which are biomarkers of ethanol, liver enzymes, GGT being the best one for recent use. Carboxyl deficient transferrin, that's gone out of fashion now. And then the ones that are currently being used most are urinary. We've got glucuronide down here as blood and hair, but in fact it's urinary glucuronide that we are using, and dry blood phosphatidylethanol known as PEth. And glucuronide has problems with false positives, and it is a few days of alcohol use will put it up. Ethanol itself is really the last 24 hours. A phosphatidylethanol is 2 to 6 weeks. And so it's a useful test to see alcohol exposure in the last few weeks. And we've applied this test with Northwestern. So this is a paper, Michael Fleming is quite a famous addiction researcher, a family medicine physician, member of the National Academy of Sciences. And we did this, he was originally with us in Madison, he then moved to Northwestern, and so we continued as a two-center study. It's a complicated picture. It's using self-report alcohol consumption as our gold standard, and then using PEth on a regular basis. The patients came for the study tests, and at each study visit, they gave their self-report, and we used patients who had a liver transplant and a background diagnosis of alcohol use disorder, and then patients with a liver transplant who did not have alcohol use disorder, and we called them controls. And then we looked at see what the self-report, the people who denied alcohol use, how did they compare to their PEth studies? And you can see in the controls, there were some people who denied using alcohol, but they still were most likely using it. PEth has a very low false positive result. Some would say a 0. And so it's interesting that some patients would feel the need to deny that they were drinking rather than have a conversation with a study coordinator to say, I was at a wedding reception, or, it was my anniversary. People always give explanations like that, and I had some alcohol. But these are patients with non-alcohol related liver disease. And then looking at the patients with alcohol related liver disease in their background, we had some patients who admitted alcohol use and they were PEth positive, but they're a relatively small group. And this group, the ones who denied it and were found to be PEth positive, was much higher. Or in this side of the picture, the PEth density was much higher. That is the PEth has a semi-quantitative capacity, so it suggests that the drinking was greater. And that goes back to this. So this is self-report here. So it's quite probable that there is missed alcohol use within these data here, and that one might find with addition of biomarkers, that these patterns are either more confused or that the percentages increase. So that gets us back to selecting patients. So I said we have a philosophical decision to decide how well we select in terms of what outcome we want. And I showed data from the Accelerate group that return to alcohol use has an effect on mortality. But in the broader group of patients transplanted for alcohol-related liver disease, return to alcohol use increases liver fibrosis and affects mortality if it's sustained, but it only seems to take a little bit longer than was seen in the Accelerate model. So by 5 years it's seen, and certainly by 10 years. So there's a real reason to restrict liver transplantation to patients who are not going to damage their liver with alcohol. But as you can see, how much mortality you can tolerate, how much delay in mortality is also an important question, not picked up by the Accelerate data set. But if you're dying of alcoholic liver disease to your transplant, is that a successful transplant? So at the University of Wisconsin, driven by my colleague John Rice, we introduced the SEPT score. And this, we've got to recognize the help we get from our medical liver transplant social workers, particularly a woman named Maureen Garvey. And she said she was happy to use SEPT because she was doing all the parts for SEPT already, because others have found SEPT very cumbersome. And here we have an abstract that's going to be presented at the next AASLD. It's looking at our SEPT patients at the university between June 2018 and December 2019. And we had 199 patients who were evaluated and presented for transplant selection committee with alcohol-related liver disease, and we compare them to 159 without, and these are consecutive patients. So that actually tells you something about our program. In terms of the patients being evaluated, we're seeing more patients with alcohol-related liver disease than all other diagnoses combined. And then I'm going to show you a little bit about what the SEPT score is. We also looked at MELD scores, and we used, I think, appropriate statistical methods. So SEPT is a 4-domain assessment. It assesses readiness, and this is in a semi-structured interview with a medical social worker in our center. Understanding of the illness and of transplantation, willingness for treatment, treatment adherence. And then there's social support. Is it available? Is it useful? What is the patient's living situation? Substance use, alcohol use disorder, substance use disorder, risk for relapse, nicotine use, and then stability, psychiatric disease, neurocognitive impairment, personality disorders. These are I had an earlier slide which I just took out, but I could put in here. As I say, this is the first time I've given this talk, which is based on studies by a person that Kim will remember very well, Tom Beresford, when he was at the University of Michigan. And he really defined 4 domains, and they're very like these 4 domains. Acceptance of the disease, social support and a home, other psychiatric illnesses, and a history of psychosocial instability. He also included frequency of prior failed attempts at rehabilitation, which would come out in this. It's just, it would be under the substance use tab. And here are our results. So among the alcohol-related liver disease patients, we approved 42%, declined 49%, and hummed and hawed over 9%. So only 42% got through in the time frame we were in. Whereas we approved 68% of the non-alcohol-related patients, and we deferred very few. We were able to make a decision much more easily. And these differences are statistically significant. And then let's looking at the SEPT scores. I'm going to show you the MELD scores. So this is a way of looking at it. But let's look, first of all, at the approved and not approved. So among the approved patients, the SEPT scores, higher is worse. are much higher in the alcohol-related liver disease patients, let's call them ALD patients, versus non-ALD. So we are taking much more vulnerable patients with ALD than patients with non-ALD. And then when you look across the non-ALD, there's a small difference in vulnerability, psychosocial vulnerability between the unselected and the selected. Small, but it had some small contribution. But then when you look across the ALD patients, even though the selected patients were more vulnerable than the non-selected non-ALD, or than the selected non-ALD patients, the non-selected ALD patients were even more vulnerable. They had very high SIPAT scores. So SIPAT made a difference. We did not accept the people who were at the greatest risk, but we still took high risks. Now, maybe this is just something to do with MELD, but when you look at the MELD scores, the MELD scores of the alcohol-related patients are significantly higher than the non-alcohol patients. So we're being sent very sick MELD patients, and it doesn't appear to have much difference whether we take them or not. The thing that makes a difference is psychosocial assessment, and that's what's shown when you do multivariate analysis, and that diagnosis is an independent risk factor, and that that SIPAT is what makes a difference, or put it more broadly, the psychosocial assessment is what's making a difference. So what are the outcomes for those patients we turn down? And these are a largely forgotten group of patients. And yet there are patients. So for those of you who know your Casablanca, the question is, when we turn them down, is it the beginning of a beautiful friendship, which is what Captain Renault says to, or maybe it's Rick says to Captain Renault when they walk off into the mist after Ilse Lund and her husband fly away. So is it, what happens after we turn these patients down? So this is another abstract for the next AASLD, and this is again work. John Rice is the first. I think he's the first, or maybe one of the fellows is one of the first authors, but he's really the leading person. So his idea was to look at those patients that we declined from for early liver transplantation, but that they were sick. They had a MELD score of 25 or greater, and they had short abstinence. So this is the at-risk group that we might have taken but did not. And in the group that we had a total of 144 patients who met these criteria, and we selected 49 for early transplantation and declined 95. Of this 95, 34 met these recovery criteria, that their MELD declined to less than 21. And they had a mean peak MELD of 30.5. So they had been sick and they got better. And this is an old observation by Bob Marion, that a declining delta MELD is a sign of recovery. And what happened to the rest? Well, the other 60s died. You'll notice there's one more. I asked John on the phone earlier this week, and I made this slide. What happened to the last one? He said, when we closed the data set, there was one hanging on with a MELD of 35. Hadn't yet been transplanted, hadn't died. But it's likely that patient will die too. But so if we don't take you, and you're in this group, and you don't see a fall in your MELD, you're going to die. So that this is a life and death decision. And then in the median follow-up of just under 2 years, how many patients recovered further? Well, 7 did. 7 had their MELD fall to less than 15. So this is not that different than that earlier data set I showed you from Tom Cotter, where 3% of the patients with AH put on the liver transplant waiting list recovered to be taken off the list. And of this 34, 16, when we closed the set, were still being treated for ascites, although no one was getting paracentesis, and 18 were being treated for hepatic encephalopathy. And regarding alcohol use, of the 34 had returned to alcohol use, and 5 alcohol-related deaths had been caused. So We have summarized this as patients that undergo liver transplantation or early liver transplantation for alcoholic hepatitis can recover, evaluation, I should say, patients that undergo evaluation for early liver transplantation but are declined can recover to the point where it's no longer indicated. Some can. However, they're a minority, and most patients will experience complications of end-stage liver disease that continue. And alcohol relapse is unfortunately common, and death from liver failure after alcohol relapse is the most common cause of death. So it's a very, very mixed picture on those patients who are declined from an early liver transplant based on what is largely a psychosocial evaluation. So it gets back to that question, what sort of mortality post-transplant are we prepared to accept as a sufficient benefit? So to go back over, we have three chapters: the view from space, re-entry, and coming home. And they're national data and guidelines, multi-center data, and single-center data. And in the national data, 36% of liver transplants are now done for alcohol-related liver disease. And more centers are taking selected patients with alcoholic hepatitis. And multidisciplinary psychological assessment is replacing a required strict interval of abstinence. But there's very little transparency about those policies, at least in what we present to patients and families before they get to the center, what they can they review before they get to the center. The present system also may be giving an unequal advantage to waitlisted AH patients. Then when we come to the multi-center data, retrospective multi-center data from the US suggests that short-term patient and graft survival are very good after liver transplantation for those selected patients with short interval of abstinence and alcohol use liver disease. Selected being the key word. Drinking relapse occurs and it's harmful. And the content of the psychosocial evaluation, rather than the designation of who does the evaluation, is most important. And we lack a consensus on what are acceptable rates of relapse and what are acceptable mortality as a consequence of that relapse. Finally, there's no one pattern of relapse. We're doing single-center data. Biomarkers increase the identification of alcohol use, but risk entrapment of the patient, and you need to consider how you use them. And I presented then Wisconsin data using SIPAT. There's very much local, individual, center-based data that shows that a group of ALD patients that we're evaluating are among the most vulnerable, even when we consider minority, and that severe alcohol AH patients who have been declined listing only occasionally recover, most die, and even among those who recover, they carry a high risk of continued liver failure and or alcohol relapse and death related to that relapse. So that's where I'm going to stop. Here is a picture of Lake Mendota and the capital, state of Wisconsin. You can imagine that space capsule landing just in front of those sailing boats. And anyone who wants to get in touch with me, anything coming from Wisconsin can't avoid including Bucky. I'm still trying to work out why he looks so cranky, but that's how he looks. And thank you for your attention, and thank you again to Kim and Marwan for the opportunity.
Thank you, Michael. That was a wonderful lecture, and we really appreciate you sharing your insights with us. There are some questions that have come through the chat box. A couple of them actually have to do with length of sobriety. In your opinion, is there a length of sobriety that should be met? Is that helpful? Or should we base our decisions more on the psychosocial evaluation and the scoring system that you outlined?
Well, I think it's a combination of the two. So There is no absolute length of sobriety, but the patient who comes in with a blood alcohol level of 200 is unlikely to be selected. So that's a sobriety length of less than 24 hours. And so where does it start getting better? So it's a combination of phenomena. If the medical social worker says, yes, but this person has had a recent crisis in their life, they've got strong structures, they've been sober before, they've never been to rehab, we will try to work with that. We'll say, well, can they get better? The problem is, if they're not getting better, if their MEL score is getting worse, they're in the ICU, and then a decision has to be made. And it really comes down to the people involved in the decision. And, you know, some of those decisions in the patient's favor, and we have made some of those decisions against the patient's favor. And you can see that it's a judgment.
So the next question is, of those barriers for people who are declined, what do you think, or have you observed are the greatest psychosocial barriers to listing a patient with alcohol use disorder and transplant?
That's a good question, because it's really been asked in that way very often, but we're writing the SIPAT paper and I will keep that in mind. I think the barriers related to poverty are the greatest barriers. So the barriers: lack of a stable home, lack of other people who are stable themselves, who can give this sort of support. So the 50-year-old man who's living with his 85-year-old mother and she's the only driver, that person is not in, and has wake, a couple of wives, adult children who are no longer seeing him. And we've seen those stories, that isolated figure with no support. So I think that those poverty, it's unfortunate, but those aspects related to poverty make it most difficult. I see Dilip. How are you, Dilip?
Well, I'm not happy, Mike. The whole point of your talk was for you to come to Michigan so we could do a giant visit. Yeah.
Were you happy is my question. So the question is, are you happier or less happy?
Well, I was going to say the final level of your talk was going to be the bar level, and we never quite got to that. All right, so I have a bone to pick with you, and then I have a question. The bone is that I'm reading your guidelines, right? And in the world of hepatology, I make it clear to our fellows that the PET test is the greatest advance in sofosbuvir in hepatology. And yet, I mean, it goes back a month, it's quantitative, and I have been told biochemically you cannot get a false positive. Yes. And yet, when I read your guidelines, it's right in there with hair ethyl glucuronide. Why don't you just tell people who don't know a lot about liver disease that this is the test?
Well, I agree with you. You know, it would be easier to, you've been involved in writing these sorts of guidelines. They are a negotiation, and this is where that came out. You know, it's a negotiation. It came out at that point. I am an advocate of the PET test. I see we have done our own little PET study journals. So I do think it's valuable. And as you said, the biochemical background is that PET cannot be manufactured in the body unless you have ethanol first as a substrate. So I agree with you. Yes, we could have been more bold in our suggestion, but every suggestion, every recommendation came back with somebody wanting to change it.
So here's my question. My question is this. You asked the question, what happens when we turn people down for transplant? What happens to them if, without the transplant? To me, the more interesting question is, what happens to people who we turn down for transplant who get a transplant? And it's sort of a weird question, but Brian Lee answered that. He said, in Accelerate, the patients with the worst scores actually had a 50% chance of not drinking. and he felt that that was low enough to do the transplant.
Sure.
So should we be turning down anyone who agrees to stop drinking?
You're asking a very good question. And Accelerate would allow a review of that. I don't know that we've actually written it up in those terms. And then we have experience, but it's so I can only think of one recent patient of mine who had previously been assessed at Henry Ford. So we don't get many patients who fly over Lake Michigan, but this one did. And I could only discuss the case with you over that drink that we were talking about some point, HIPAA and all those things. But you are correct. That is so that study has been done in a different way. It's just by tangential remark. Sandy Feng and John Roberts have written about the outcome of livers that, and they do great. So the fact that a liver has been turned down 5 times doesn't mean that the 6th center is going to find that it's a real lemon. No, they often work. They usually work, actually. So that's one aspect of the selectivity and arbitrariness that's involved in liver transplantation. And I suspect we might find the same if we were able. So it'd be great if one could get a data set large enough that 100 patients turned down and look at. I really like to be able to go to the original center and do the sort of analysis that we have done in Accelerate on the selection assessment and what it contained, and that would be an interesting review.
Dr. Lucey, thank you so much. We are past the hour. There are still good questions, and I would urge the attendees to use your email to address these important questions. Clearly, in the alcoholic liver disease and transplant space, we have yet a lot to learn going forward with the advent of these new surveys and scoring metrics and the use of PEth. And I hope we can arrive at a good understanding that communally we all agree of how we're going to approach this population. So I can't thank you enough for making the time to speak to our collective audience here in Region 10, and wish you the best. And hopefully by the next meeting, we will have this problem solved.
Good.
So much.
We'll just find a new problem. Thank you very much, Mauro.
Have a wonderful day, and thanks
Thank
again.
You, Kim. Thank you, Jill.
Greetings from Detroit.
Bye-bye.
Bye-bye.